This video demonstrates an interhemispheric transcallosal approach to debulk an optic pathway hypothalamic glioma. This 9-year-old girl presented with visual deterioration. The surgical approach is demonstrated in more detail on the separate video. As you can see, an interhemispheric dissection is made, exposing the corpus callosum, and then a callosotomy is performed. The right lateral ventricle is then entered, revealing the tumour projecting through the foramen of Monro. The capsule of the tumour is cauterized with diathermy, and then biopsies are taken for frozen section and for formal pathology analysis. The posterior aspect of the tumour capsule is then dissected free from the foramen of Monro, the thalamus striate vein, and the choroid plexus. Then the superior medial aspect of the capsule is freed from the anterior septal vein and the column of the fornix as it runs along in the base of the septum pellucidum. Internal tumour debulking is then commenced using the Cusa with the extra long handpiece, and then more dissection is performed to free the capsule from the thalamus striate vein and foramen of Monro. A subchoroidal dissection is then performed to separate the choroid plexus from the internal cerebral vein. This manoeuvre opens up the foramen of Monro posteriorly, allowing access to the third ventricle. The posterior aspect of the tumour capsule is inspected and found to be adherent to the thalamus in the wall of the third ventricle. Further medial dissection is now performed, and note that there is a non-stick patty placed over the column of the fornix to protect it from injury. After further internal debulking of the tumour, the capsule can then be freed and released from the contralateral foramen of Monro, and you can see the ependyma of the contralateral ventricle now coming into view as well. On further inspection, the tumour capsule is found to merge with the fornix. To avoid forniceal injury, therefore, a deliberate rim of tumour will be left in this region. The dissection is then continued with internal debulking using the Cusa, and then also using suction for the softer parts of tumour towards the base. After further internal debulking, the navigation probe is inserted to confirm the location and extent of resection. The centre of this tumour contained an awkward vascular pedicle, which you can see me now dissecting out. The final portion of these internal vessels is cauterized and then divided. And now a block of tissue is also removed from the centre of the tumour. Ooze from the side is controlled with a hemostatic mesh and a cotton patty, and dissection then continues at the back of the tumour capsule with internal debulking, and then dissection of the capsule away from the third ventricle and medial wall of the thalamus. The extent of right lateral dissection is then checked using the navigation probe before performing further debulking with the Cusa, both laterally as well as medially, and then anteriorly as well. So in this manner, a central block of tumour is removed, and then the dissection continues out wider within the tumour cavity itself, out towards the walls, but also towards the floor that you can now see being dissected and debulked. The navigation probe is then used to check the extent of resection, both in terms of the deep margin, but also the left lateral margin, the right lateral margin, and anteriorly and posteriorly as well. You can see these illustrated on these screenshots taken during the surgery itself. They confirm that the aims of surgery have been achieved, so surgery is now halted. Hemostasis is obtained with the patient normotensive. At the end of the procedure, a septal fenestration is performed to ensure that the CSF pathways remain open. This is checked with a saline flush. The retractors are removed and the cavity is inspected to ensure that hemostasis continues. There were no complications in the immediate post-operative period, and she had no evidence of diabetes insipidus. The scans confirm an extensive resection with a planned small remnant of tumour at the base and sides where it abuts the hypothalamus.